not around. So I think we'll go live, and we'll ask the operators of Dr. Hatim and Dr. Khalid Saidi. They are the main operators, and they are going to present the case, and then we'll have the discussion about it. Because we know that bicuspid aortic valve invokes difficulties in all the steps of TAVR. Starting from the assessment, even in the echo, you go to the CT, the measurements, and the selection of the device, to the crossability, because usually the opening is very eccentric, to the implanting the valve. So we'll go live soon. Hello.
Good morning. Assalamu alaikum.
Assalamu alaikum. Khalid, good morning.
Good morning.
So,
How are you doing?
very good. How are you doing there?
We are doing great.
Okay, so do you want to start with introduce the team and then start with the case, please?
Sure. So good morning, everyone, and welcome to this live transmission from the National Heart Center at the Royal Hospital in Oman. We have a very interesting case that we hope is going to generate a rich discussion. My name is Hatim Lawati, and I am joined today by an A team. I have with me to my right Dr. Khalid Saidi, who is a consultant interventional cardiologist in the center. We have on anesthesia Dr. Mohammed Al-Na'abi, Dr. Haifa Al-Za'abi, and on the nursing team we have Kauthar, we have Layla, we have Nizar and Ahmed, and we have an esteemed team of technologists, including Salim Al-Maqbali, Ahmed Al-Kilbani. Salim Al-Maqbali will be on device preparation. So we'll dive right into the case. Our patient is, next slide please, is a 75-year-old legally blind man who is hypertensive, diabetic, and dyslipidemic, and has advanced diabetic nephropathy. He's not yet on dialysis. He has atrial fibrillation, and in 2017, he had a stent to his mid-LAD for crescendo angina. Early in 2022, he presented with progressive exertional dyspnea, which eventually progressed to dyspnea at rest, and somewhere towards the end of 2022, he was admitted to a peripheral hospital with acute pulmonary edema. A transthoracic echocardiogram done at that hospital revealed severely depressed LV systolic function with an estimated ejection fraction of 25 to 30% and a dilated left ventricle. The aortic valve appeared quite thickened with restricted systolic excursion, but with discrepantly low transvalvular pressure gradient measurements. He was discharged with anticoagulation, diuretics, and good anti-remodeling therapy, but continued to be symptomatic, so referred to us for further evaluation and management. He continues to endorse NYHA functional class 3 to 4 symptoms at baseline. Next slide, please. Our echocardiogram, can you run the clips? As you can see, the aortic valve is quite sclerotic with a severely restricted systolic excursion and somewhat of an eccentric valve opening, suggesting a possible bicuspid morphology. Both the left ventricle and left atria are markedly dilated, and in the short axis images, the morphology is not 100% clear, but it appears to be bicuspid. Next slide, please. Can you run the clips? The LV systolic function, as you can see in the apical 4, apical 2, and short axis, is severely impaired. Next slide, please. Multiple measurements were obtained for the transaortic pressure gradients given underlying AFib, and the mean gradient averaged over multiple cardiac cycles was about 18 to 20 millimeters of mercury. In addition, the patient appeared to have a bicuspid aortopathy with an ascending aorta that measured 44.4 millimeters on the transthoracic echocardiogram. Next slide, please. The patient underwent a dobutamine stress echocardiogram to try and tease out true low flow, low gradient state from a pseudostenosis. The ejection fraction on volumetric assessment at baseline was 30%. His aortic valve area measured 0.98 centimeters squared and 0.55 centimeters squared index to his body surface area. The mean pressure gradient was 18 millimeters of mercury at a stroke index of 28 moles per beat per meter square body surface area with a Doppler velocity index of 0.21. And at 20 mics per kg per minute of dobutamine, the ejection fraction augmented to 45%. The area measurements remained essentially unchanged. The mean gradient picked up from 18 to 37, as did the stroke index from 28 to 35 mils per beat per meter square body surface area. These measurements, as you can see, are consistent with a true low flow, low gradient state and suggests adequate contractile reserve. Next slide, please. Coronary angiography before his TAVR revealed moderate plaque burden in the proximal circumflex and the proximal LAD. The stent that was previously implanted in the LAD was widely patent with no ISR and no stent outflow issues. The right coronary artery, next slide please, was a dominant vessel with focal stenosis in the posterolateral and the posterior interventricular branch of the distal right. Next slide, please. So if you plug in the patient's data into the surgical risk calculator, we end up with an estimated STS risk of 10%, placing him at a high surgical risk. The patient was discussed within the heart team meetings, and it was no-brainer that he required a TAVR for his aortic valve. Next slide, please. Next slide, please. So the CT data is summarized in front of you. Next slide, please. Yeah, they're showing the old version of the presentation. Never mind. Can you show us the CT data?
For what?
No,
Go back.
the table, please.
Go back. Yes, here.
All right, so the perimeter at the annulus measured 85.8 millimeters with an average perimeter-derived diameter of 27.3 millimeters. The mean LVOT diameter is 28.6 millimeters. The ascending aorta was dilated and measured 43 millimeters at its maximum dimension. The aortic valve, as you will see, was confirmed to be bicuspid in its morphology, consistent with a Sievers type 0 bicuspid valve configuration. The sinuses of Valsalva are quite spacious, with adequate sinus of Valsalva heights and adequate annular coronary osteal heights, both on the left and the right. So if you show us the next slide, so moving up into the supraannular apparatus, you notice the elliptical configuration of the valve orifice. The intercommissural distance at the annulus measured 30.5 millimeters, and 5 millimeters up and 8 millimeters up in the supraannular apparatus. The perimeter measured 79.4 or 79.5 millimeters with an average perimeter-derived diameter of 25.3. Next slide, please. This is a 3D rendering of the valve showing a Sievers type 0 bicuspid aortic valve configuration. What is interesting to note is there is very little in the way of calcification in this valve. It's quite fibrotic in nature. In addition, as you can see, the angle between the aortic annulus and the aortic root is approaching 70%, suggesting a horizontal lie to the aorta. Next slide, please. And this is again seen very nicely in this 3D reconstruction, which also shows that both the left and the right coronaries arise from the same coronary sinus. The proximal ascending aorta has a focal dilatation. This is where it measured 43 millimeters. And he has a bovine aortic arch as well, with a left common carotid arising from a common origin with the brachiocephalic trunk. Next slide, please. In terms of access, He has conveniently low common femoral bifurcations on both sides. The bifurcation is below the femoral heads. The common femoral artery measures almost 9 millimeters on both sides with very little calcification. The external iliac measures 10 millimeters, and the common iliac measures between 11 and 11.7 millimeters, and again, with very low in the way of calcification. And these were the suggested angles for implantation. Next slide, please. So I'm going to pause here. We presented quite a lot of clinical, echocardiographic, and CT data, which we need to think about very carefully and understand and digest in planning for our procedure. The case obviously highlights a number of nuances that are particular for TAVR in bicuspid aortic valves as compared to TAVR in your usual tricuspid valve. It'll be interesting to see how the panelists would approach a case like this in terms of sizing, in terms of implantation technique, tips and tricks in negotiating the horizontal aorta. So I'd be curious to hear some input from the expert panelist team.
Thank you very much, Hatim. Two questions for the panelist. First, will you dilate or not? Since the valve is fibrotic rather than, there's not much of calcification. Second thing, what will be the size of the valve you'll be using? We'll start Dr. Wael.
Yes. First of all, this case is a very challenging case. Thanks, guys, and I hope it will be a very good case. I think pre-dilatation is mandatory in this case, at least from my point of view. And the sizing is the tricky part here. 34 valve, because it's you have a perimeter of 27. If you go for 25% over sizing, it will be a 34. But I think with this supraannular diameter of 25, 34 might be a little bit oversized.
Okay, Dr. Tariq.
So, a very interesting case. Several challenges. Of course, you're faced with a depressed LVEF. So, this is something that's going to be affecting your hemodynamics during the procedure. It's an unusual case because you have a true bicuspid sievert type 0 that's presenting at the age of 75 years old. So that's a late presentation for that. You have a dilated aortic root, which will play into your deployment technique and how you anchor and leverage your wire to manage a horizontal aorta. In terms of pre-dilating, we usually do pre-dilate for bicuspid, although the calcification here is not as severe as you would expect with a bicuspid valve.
What size of valve you will? Sorry, with balloon.
What size of balloon?
Yeah.
I would undersize, so it was probably 23 to 24.
Yes. Great.
And I would probably use the annular dimensions for sizing of the valve. I know they've been...
Not supraannular. Not supraannular dimensions.
We usually go with the annular, especially if you're using a self-expanding platform.
Okay.
That would minimize the risk of annular rupture.
Great. Dr. Wael.
Definitely, the intention of the procedure is to use a self-expandable valve. So definitely we'll use we will do pre-dilatation, and for the sizing, I usually use the balloon to measure and to get the idea of the size of the balloon. So for example, the annulus here, it's it can take up to 25 balloon. We don't need to go up to 25. There is no extensive calcification. It's a bicuspid. It's fibrosed. If you go with high balloon, although it's relatively rare, he can go to acute AI in the presence of severe LV dysfunction, and there will be no time to help the patient. Anyway, you don't need to go to that much high of balloon. I will take the 23 balloon. I will do injection during the inflation, a good injection, 20 cc contrast 25 cc contrast at 800 or 900 psi. Look for if there is any paravalve, if there is a leak around the balloon. If no, I will use the 23 balloon and we use the equation for the supraannular calculation. I use the 23 of the balloon plus the derived perimeter of the valve by CT. Here I think it is 27. If 23, the balloon sealed, there is no flow across the balloon, I will use 23 plus 27. That will be around 50 divided by 2. The 25 is your valve. If the 25, the diameter, it's between, for example, 29 and 34 valve, I will go with the 29 valve definitely. 34, you don't need to go for 34 in this patient. Don't oversize the balloon. And there is no extensive calcification. It will give you good result. Regarding the horizontality of the aorta, I don't think it's a big issue here.
Thank you. Dr. Ramesh?
Yeah, I think I agree with everyone. I always pre-dilate all bicuspid valves without any doubt. I use a 24 millimeter, either true dilatation balloon or Atlas Gold for pre-dilation of these. And I mean, obviously, balloon expandable or self-expandable is whatever we think about it, but there's no data to support one or the other. In our center, we use a 34 millimeter or a 29 sapien, 34 millimeter evolute or 29 sapien in this patient. But that said, I just want to make up one point is that do not actually just turn down every patient for surgery. Our center is one of the centers in the world that started robotic aortic valve replacement. Faraz Khalil from Saudi Arabia has also visited our center and trained. And ability to just do these patients, as long as they don't have CKD stage 5, with a simple 4-inch incision on the right thoracic, right midline, mid-axillary line, and they go home in 3 days, is no inferior than a TAVR in young people, especially when you're addressing low-risk patients with recent PARTNER 3 and Evolute data, which shows structural valve degeneration is slightly more. And be cautious about low-risk patients. Not in this one, but in general.
So just I'll throw one question. What's the risk of coronary obstruction in such a case, especially the two coronaries are arising from one sinus?
No,
So I think the coronary sinuses are quite generous,
yes.
and I think this is not going to be a big issue here. And the heights of the coronaries are okay.
Okay, very good.
What we do have to be mindful of is that the patient does have advanced kidney disease, and if we're going to do balloon sizing with aortic injections and access injections, it's going to take a toll on the kidneys, and that's something that to be taken into consideration.
One thing also about balloon sizing, because some people, they say upgrade it by 2 millimeters till you see no leak. But the problem with every inflation, you are running a risk of stroke in these patients. So. Plus, it has a patient with LV, severe LV dysfunction with this rapid pacing and depression of the flow. He might deteriorate. Yeah. So, Hatim and Khalid, what did you do so far? Did you hear the discussion? Or?
Yes, we did. Interesting.
We did. So I'm going to let Dr. Khalid share with the panelists and the audience what we've done so far, including the hemodynamic tracings. But to summarize, we have a high-risk patient who's 75 years old with advanced kidney disease, who has severe low-flow, low-gradient aortic stenosis with an adequate contractile reserve, with a bicuspid aortic valve morphology and a horizontal Y that we're planning to treat. So Dr. Khalid, do you want to share with the panelists what we've done so far?
Yeah, so far we obtained the access in the right femoral artery, and we put the 14 French sheath there. And we got alternative access in the left femoral artery, and we have a pacemaker from the left femoral vein. And then we went to cross the valve. It was extremely difficult to cross. Eventually, we were able to cross with Teromo wire, actually. We crossed with Teromo wire, and then we did BAV with aortic root injection. So we can show you that.
Can you show us, please?
Oh, sorry, before that, also we obtained hemodynamics. So maybe we can show the hemodynamics first. So can you please show us the screen of hemodynamics?
By the way, Khalid, what the ECG looks like?
So the ECG is AFib with normal QRS duration.
Okay, great.
Narrow complex. Narrow complex.
So just show us the simultaneous LV-LA tracing pre-BAV.
So you balloon the valve with what size balloon?
23.
Okay.
We want to show you the hemodynamics, so we got a mean gradient of 19,
Okay.
and with ectopics it's going to 30. Mean pressure gradient across the aortic valve. So this is, we know this is low flow gradient, severe aortic stenosis. And I think they are unable to show us the hemodynamics.
Okay, there has been a drop in his gradient after,
Ballooning.
can we show the AV, please?
Can you show us the BAV? Yeah.
So this is the balloon valvuloplasty with contrast injection. This is a 23 millimeter balloon.
So, great.
As you can see, it completely seals the aortic orifice, and there's literally no leak around the balloon as we're injecting in the root. And after this, can we check his simultaneous, can we check the mean aortic valve gradient now, please?
So what kind of balloon you used for the?
We used Edwards, 23 millimeter Edwards balloon.
Okay.
Okay.
Okay, so one of the important things for this technique for sizing is to use a semi-non-compliant balloon, not compliant balloon, because it gives you the accurate inflation measure and avoid to use a super non-compliant like Atlas Gold, for example, because the risk of causing a tear in the leaflet. So something like a crystal balloon or Z-mid balloon will be the best. Regarding your point of difficulty of crossing, I would, if in such anatomy, using the Amblatzer catheter will direct your catheter most of the time to one of the sinuses bucket. One of the easiest way I learned from my congenital training and experience is to use the right Judkin 4. You push it all the way, then pull it slowly with a small clockwise, and then you push the wire. It will give you a very successful crossing.
Okay.
So those points were taken into consideration at the time of BAV, and that's why you notice the slow, gradual inflation of the balloon. So based on these findings so far, what would be the suggestion from the panelist for the prosthesis size?
Yeah, Dr. Ramesh Dagabati here. I think if you're going with the balloon expandable, 26 appears to be okay in this with this root aortogram. And if you're going with self-expandable, I still will go with the 34 millimeter evolute.
So Dr. Ramesh is voting for 34.
No, it looks like that they are already chosen Sapien.
Yeah, not Sapien.
No,
Because it's a 14-French sheath and they used an Edwards balloon.
It's electronic.
No, it's electronic
Okay.
valve.
So-
Evolute with the, actually we just introduced the FX system, which has been introduced in the Gulf states for the last just only 3 months. It has been available in states. It's a new delivery system with one spine and good flexibility and the tapered nose cone.
Yeah.
So we are using Evolute FX system for this patient. So
34.
you vote for what? 29 or 34?
34.
34?
The
Wael, 29?
Definitely 29.
I will vote for 29. Tariq?
29, sure. After this 23 balloon ceiling, 29 should be.
Yeah, I think I would go with annular sizing. I would go for a 34.
Okay.
So just if you go, you show us that the CT report in the slides. I want just to tell you that don't look at the usually we do overexpansion using a valve, overexpansion of 15%. We feel it's safe. And if you look at this measure, 29 will be over expansion of 4% in the actual report, but that is the annular size. If you go with this balloon size in the supraannular using 29, definitely it will be around, you multiply it by 1.5 or 2, it will be around 15%. I think 29 will be very reasonable here.
Okay, Dr. Faisal?
Can you turn the mic on, please?
So we have one more comment from the audience, Hatim. Then, guys, you tell us.
I just want to thank the operator, but I am sitting in the audience and I'm just getting two messages now.
Yeah.
You want to size by balloon and you want to size by CT scan. There is data for both, but what is the strongest data is actually you look at your annular type and is it the taper, flared, or the tube type. Based on what Hatim showed us, it is the taper type.
Yeah.
So you could choose from the beginning to go to 29, but I understand why some of us choose the 34. The annulus is generous. So if you're going to go with the 34 here, there is definitely no constraint. Personally, I would not balloon size here because of what Hatim mentioned in his case, LV dysfunction. And the general rule for bicuspid pre-dilatation also follow the calcification. You have a very low calcium score, no calcified RFI. So if you choose to balloon size or to pre-dilate, great. If you choose not to, there is no penalty in this specific valve.
Thank you.
Okay.
The only challenge with the 34, it is less maneuverable and less controllable than a 29. The 34 has a mind of its own. It will land where it wants. And it's a little bit more challenging to control, especially with the horizontal aorta and the dilated aortic root.
Unfolding sometimes is a problem.
Unfolding can
So let's take a vote from the audience. Who gonna vote for 29? 34?
So 50-50.
Yes,
So
almost-
let's see what
Almost
like-
equal
like
numbers.
Go to the panelists. So Khalid and Hatim.
Go ahead.
Yes. So basically, we decided to go with 29 millimeter valve, respecting the supraannular diameter measurements. So we are going with 29. And we are actually had the valve already opened and ready. And we are ready to go if no further discussion.
One of the thing make you feel confident about your valve size is using the balloon. Tapered, not tapered, all this is, it depends on the reader, on the experience of the center. Doing this procedure in different places, knowing the capability of each center, the best way is to use balloon sizing.
Okay, thank you. By the way, the bovine aorta, what we see in the CT, it's not a true bovine, actually, it's a misnomer. Because in the cattle, it's only one trunk, not like this case. So we always see these reports of bovine aorta. Does it make any difference for us as interventionists? I don't think so. It's mainly for our colleagues, the surgeons. So guys, do you want to proceed?
Sure.
Okay.
So
All right.
get the valve.
So do you want to show the valve and the delivery system? Can you put it on the screen, please? And
Signature. You mean the signature?
Yeah. So can you show us the scene where we did the device check?
So show us the sin.
Go back. 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 Yeah.
No, this one.
yeah.
So we are showing you we checked the device, as you can see, and it looks a good load. And now we'll show you the device itself on the table. We can get the camera. Okay, so it looks very similar to the previous generation, but they did some improvement. Basically, if you can see, I don't know if it is clear to you, the nose cone is now longer. It makes it easier to enter. It's like a dilator, now acting like a dilator. They improved the capsule, and now we have one spine instead of two in the shaft, and they optimize the stability layer to give you more predictable deployment. Otherwise, the valve is the same. There are new things in the valve, which is the radio-opaque markers. So we have 3 markers for commissural alignment, and we'll show you that live, inshallah.
Okay.
So Hatim, speaking of commercial alignment, how do you think that's going to work out with a type 0 sievert bicuspid aortic valve?
So that's something that we've been discussing in the background quite a bit in the past few days. If you remember the 3D rendering of the valve in short access, it does eventually give you the Sievert's zero configuration, but there is a rudimentary left cusp which is fused with the right cusp. So I don't think we have a full understanding of what the cusp overlap view means in situations like these, but knowing that we have a rudimentary 3 cusp, we're going to apply the same concept here as well, and the same technique in ensuring commissurial alignment in the cusp overlap view.
Possibly, but I mean, we definitely, especially in bicuspids, I mean, you need to think about what wire do you need to place. Even though it is a single spine and it is a horizontal aorta, we need to be thinking about a couple of things. One is what wire do you want to place, how aggressive you want to push, because there is aortic root dilatation. You can cause aortic root dissection on this patient. I had one mortality as such. So you need to wonder about actually putting a snare in the left ventricle, trying to pull on the snare to help you advance. Even though this is very trackable with a single spine, it is not as trackable as a balloon expandable valve. We need to be very careful in evaluating all of these when you look at the system. And to Dr. Vile's point, 29 and 34 we are discussing a lot, especially in bicuspid with that funnel type of annulus. You can actually have an invagination of the valve. So I think you need to look at, if you choose a larger valve, you may have an invagination of the valve and you have to still change the valve. So I think all these points are very good.
Agreed.
So guys, you will take 29, and do you have 34 ready just in case after 80% of deployment?
Yes, we have.
Okay.
Yeah.
So
regarding the wire, we went with Lunderquist, knowing that also this is a horizontal aorta. So we have Lunderquist in the left ventricle. We are going to put it now.
okay.
So that's a very good choice to go with the Lunderquist. While you are advancing, push a little bit the wire inside, and this gonna give you when you reach near the valve, because your wire is a bit deep in the LV, you can pull little bit to deflect the device toward the aortic valve itself. So one of the key in such horizontal aorta, keep the wire deep inside the LV at the beginning. It gives you some space to maneuver by push in and pull out to direct your delivery system.
Yeah.
Make sure the wire deep in the LV.
Yeah, we have plenty of space in this dilated LV to position the wire as we want, so I think we'll do that. So aisle projection, please. So we've parked a pigtail catheter in the LV. We're advancing the Lunderquist.
So he's doing this live now? Or?
Live, yes.
We are live here. We are.
So you cannot keep the problem with this Lunderquist. We cannot keep it because inadvertently somebody just can push the wire when it is seeing it coming back. That radio opaque part is soft, but the body is so stiff. I had one LV laceration with this, and taken to surgery immediately, the patient after the implanting the valve. So the soft part is okay. It's just when you push that hard part, it's pushing against the wall of the ventricle and can cause perforation.
It will not. Yeah.
Okay.
You can push the whole thing,
Okay.
Just want to get the...
do it للفرورة شباب يعني we cannot afford losing the wire now, especially.
No, we are on live flow.
Yeah, sure. Okay.
Yeah, you still may be under papillary muscle.
I think if you push it, it will be fine.
Okay.
We probably are, so let's just advance this all the way.
It caught in the cord, the tip of the catheter.
Right.
Come back.
Now it's in the
With the catheter.
Shabab, why not the Confida? We don't have a Confida or what? Or just you've chosen the Lunderquist?
We chose the Lunderquist to give us some support to negotiate that horizontal aorta.
Yeah.
Actually, Safari is the safest among all the wires. Safari is the safest. This is actually the request
Push the whole
is
thing to the
the
center.
stiffest.
Yes, yes.
Backmire
yes.
is behind this one.
Yeah. Push now the whole thing. Again, it will go to the apex.
It's against the pap muscle.
Okay, how about we switch to exchange length one? Push everything inside and we'll switch the one. Agree?
Okay.
Yeah, can we get the exchange length, Jawad? It's ready to go.
So with the FX system, actually, you're right very much. Now we, for up to 29, we don't have to use Lundaquist. We can just go with
Safari.
with the
Safari, because
Safari or
Safari is,
Confida.
yeah.
Confida is cheaper
I
and very
always-
cost-effective guy. I'm
always
from
get
United
the
States. I'm not
Yeah.
Safari
like
is-
Tarek. So Confida is actually almost half the cost of Safari, so we prefer that. And obviously, in people with horizontal aorta, 34 bicuspid valves, I do choose Lundaquist in that.
Yeah, okay.
But as I told you, Safari is the. Yeah.
Okay.
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 So we'll change to 100%.
Okay.
Take this.
Well, very generous LV.
Yeah.
Yeah.
Yeah. Okay.
Take this one.
And actually spending that extra 2 minutes to exchange with a regular J wire will save a lot of complications such as lacerations of the left ventricle or getting caught in the chordae and papillary muscles.
But there are people that's minimizing the interaction between the stiff wire during the lengthy procedure, between the stiff wire and the LV, because the complications has been reported. I mean, and especially with these, especially Lundaquist. It gives you good support and can go into the greater curvature where you want it, but the price that you have to be very,
Push the whole
very
thing, it will
careful.
go.
There is a wire from Medtronic. It's used sometimes just to slash stiff. I forgot its name. Anybody knows about it? From
Which one?
wire from Medtronic.
There's a new wire from Medtronic.
Yeah, it's not available in the United States yet. It came to OUS first. Yeah.
Yeah.
They only use
Doctor.
Yeah.
Ahmed, I would like to ask, everybody is
Let's
talking
go
about
with it.
papillary muscle maybe issue. How many papillary muscle you have seen ruptured from the TAVI?
We need to take out
I
this.
never seen it
Yeah.
from the wire causing an issue because your valve opening gets at the just
You will hold
only
the
at
pressure?
Yeah.
below the sinus or at the sinus itself.
But Abdurrahman will describe, hypotension during the procedure from mitral regurg related to something
papillary
trapped in the papillary muscle, and with this
Trapping it where?
with
Inside
the wire,
aortic valve?
with the wire itself, and we'll describe. Then hypotension. Why? For no reason. Yani.
It's probably not papillary muscle rupture, but the acute MR during the procedure causing hypotension and not actually, then you're stuck. Now you cannot remove the wire because your valve is halfway through, and then
No,
you're...
you can, the wire, you can keep it as it is, bring your valve, once you cross,
sorry,
pull
can
your
I-
valve, adjust it.
Okay.
Yeah, you're right.
Can I interrupt?
So Abdurrahman, we go with the safest procedure.
Okay. Yes, Khalid, Hatim.
Yes. So here we go. We'll show you just the procedure for commissural alignment, regardless of how important here. So the flush port is at 3 o'clock, and we advance and we let the catheter take its shape, and then we check in the descending aorta again.
So can you go back to the AP projection, please? Yeah. Okay.
So we let the catheter take the shape of the anatomy,
So we're in the descending.
and then here we just make sure that it's still at 3 o'clock. Otherwise, we'll adjust it. So now we can go LAO and proceed.
LAO, please.
Okay.
So here, we'll just show you this. The orientation of the hat marker towards the outer curvature of the aorta. Our wires conveniently at the LV apex will slowly track over the wire. You have a wire?
Yeah.
I'm going to just pull the pigtail back so it doesn't get dragged with the prosthesis across the valve.
is sufficient here.
The nose cone now is just across the valve prosthesis. Sorry, the native valve.
Okay.
And you see the hat marker remaining in the outer curvature.
So I'll just sinew that. So the hat marker is still against the outer curvature. We'll advance the pigtail catheter down to the, there we go. That's the nadir of the non-cusp there. Okay.
Can we go to cusp overlap?
Yeah.
So you'll go for the cusp overlap or the coplanar first?
We'll go and act with the cusp overlap.
Or not yet?
Okay.
So it's 10 RO, 24 caudal.
Okay.
Did
We're
you
going
cross
to
or not yet?
Not yet.
Well, not yet. The nose cone is inside.
Okay.
Centers, please. Centers? No.
So,
Two
Dr.
or three.
Ahmed, you want to, we have one comment from the audience, guys. Okay.
Can you turn that mic on, please? The second mic.
Dr. Ahmed, can you come for?
Yeah.
It's on now.
Yes, so I totally agree with the lender request for another reason as well. It will deliver the valve very horizontal when you deploy it, rather than it's pointing toward the mitral. The look of it will be better, as well as the risk of PVL will be better for this very horizontal aorta. I think with the effects, he didn't have a problem delivering the valve up to the aorta, but the problem is going to be with shaping the valve into the angles.
Thank you.
Come close.
Okay.
Click on. You're coming. You're coming.
Okay.
That's an excellent comment.
Okay.
That's it.
Okay.
That's it.
Okay. Do you want to start?
So what is the depth of the deployment in this bicuspid aortic valve? Do you go 2 to 3 millimeter below the annulus, or you go at like 0 to 1?
We were going to adopt the latter strategy, 0 to 1, in anticipation of the prosthesis diving into the ventricle at the time of deployment.
So,
So we'll just realign the hat marker, and we are trying to align it with the end of the pigtail catheter, as you can see here.
okay.
It's right down at the nadir of the non-cusp. Is this okay?
Yeah.
All right. I think we'll.
Assuming this valve now is more stable,
Okay.
so we'll start here, we'll not start higher, and then we'll see the behavior of the prosthesis, and then we can adjust accordingly.
Yeah, having the markers on this FX valve actually helps us, and I still think 2 to 3 millimeters is acceptable or is actually preferable for in my opinion. Even in bicuspid, this is a supraannular valve. We are not really worried about the hemodynamics in this type of valve. So it will be much better than any other valve that is available currently.
Okay.
I agree with you.
So we'll go 2 to 3 millimeters below.
Yeah, I will go 2 to 3, especially, sometimes we go 0 because I need more radial strength, but this is not a calcified valve, fibrotic. I think 2 to 3 millimeter will be fine.
Okay.
I feel it's a little bit high.
Yeah, little high now, I think.
Yeah.
There.
We'll see.
There. We're advancing it now. Okay.
So you are keeping tension on the valve?
We are.
Yeah, we are keeping tension, and I think I will go to 80% now. We're going to 80% deployment and reassess.
Okay.
I think
Abdurrahman?
Yes, it's popped down.
Abdurrahman?
Dr. Muhammad,
Yeah,
there is a difference between
Now it's
the
good.
conventional, the effluent plus or effluent R and the FX.
Affects only the delivery.
The effects, releasing the valve, the markers, all the markers in one line below the pigtail, because this difference is the pigtail. Different from the previous effluent, starting from the mid-ring of the pigtail, the valve will dive. The effects does not dive in, it stays as it is. So start from the level you want and don't modify, just stay complete release until you open your valve. At 80, then assess.
Yes.
Because the valve does not move if you start through.
One of the important things related to the marker. When you start to release and you see the 3 marker in front of you, you can eliminate the parallax by moving caudal or REO. Just make it on one line. It will help a lot for give you the actual depth.
Okay, so this is an injection.
So how do you feel about
The depth.
the depth so far?
I would eliminate the parallax because I can't see the marker in different.
مشكلة الشاشة هنا
Yeah.
صعبة يعني ما تشوفها.
Yeah, in this view, it looks, the depth looks okay. Are you in, can you go to
How about we check LAO?
LAO?
Sorry?
Let's go LAO.
Just go and remove the parallax, please.
Just
the parallax.
just come caudal a little bit. Just come caudal. Oh, that's.
So here is
Yeah.
Studio.
Go LAO.
LAO. And coded.
Just come further. Keep going. That's it.
Definitely, it is too deep.
No, this is come more further. Keep going. Yeah. A little bit more. Caudal, please. More. I think this is probably better.
Okay,
This is better.
this seems too deep.
I mean, is the parallax completely out?
مشكلة ما تشوفها.
Maybe a little more caudal. Come a little more caudal.
Can you see well? Or?
That's it. So here,
ما واضحة.
That's better, I think, now.
yeah. Here, the depth doesn't look that bad. Let's check an injection and see.
Okay.
Okay? Doesn't look bad here. What does the
Yeah,
what do the panels think?
Yeah, you're about 3-4 millimeters. I think as long as you are confirming that parallax is completely out, I think the non-coronary side looks very good, and even on the left side, left cusp also, it looks at least 4 or 5 millimeter deep, and it'll settle down. You know, once you pull back your wire, I think it'll settle down.
Yeah. Okay. I think we'll proceed.
Okay.
It's acceptable.
And you see, for commercial alignment is like 1 dot in the right of the screen and 2 dots in the left.
Just forget about the commissural alignment now. Give us a good depth and
It's a
that.
bicuspid valve
It's a
anyway.
bicuspid and
So you want me to
Yeah.
pull the wire?
So pull the wire back.
Okay.
Okay.
Okay, so
Yeah.
So we'll go for a final release.
All right.
yeah.
Okay.
I think it will be difficult to manipulate.
I'm not seeing.
Yeah, I'll pull it back.
It's not clear.
Do you want to pull the picture? Okay.
So don't do the final release until you go LAO caudal, eliminate the parallax, keep the 3 bots near each, like in one line, to actually give you
Go
the
more LAO.
No, we're talking to the audience. You're explaining to the audience, right?
Yeah.
Yeah.
So I think he is an LAO view, and he's trying to get.
Yeah,
the
we are
parallax.
in LAO. Yeah, we are in LAO 26, codal 37.
Hatim, I think that there's concern about the parallax with the 3 dots not being aligned. We don't see it as here very clearly.
Let me give you a dry cine here. The 3 dots appear to be aligned now.
Better
Can you see that?
achieving.
Yes, you are
They're
correct.
aligned now.
Yes, much better, sir.
Can we make
Okay.
an injection?
So, okay.
oh that's
We'll
look
take an
at
injection here.
great position. In fact.
Yes, that's
Okay.
good. That's
Great.
Excellent.
Yeah, that looks very good.
Okay, so let's just pull this back.
Yeah. You hold the valve forward, pressure and opening.
Yeah.
So we are opening the valve now.
Okay.
I think we are happy with the position.
Yeah. Okay.
Are you pacing?
No.
Heart
We are
rate
not
is.
pacing. Because the issue is he may not tolerate pacing.
We're worried about his LV function,
So
not tolerating.
just slow on the release so it doesn't jump on you.
Yeah.
okay. It's released.
Okay, we are fully released now.
Excellent.
Great.
So let's get the.
Okay, yeah.
Keep the wire.
Be careful the wire.
Can you fix this?
Yeah.
Can you come back to the AP projection, please? Sorry.
Okay. Can you go to the RAO and just
Yeah, we'll do that in a moment.
go to the inject for the to see the if there's any PVL.
Yes.
Okay, come on, please.
Yeah, so change to 20. Change to 20, please.
Should we go to the wire?
Should we remove the parallax, because here are the parallax in this video.
Yeah.
How about our first view, which is the LAO?
I think the panelists wanted to see an aerial projection.
You want to see an aerial projection?
Yeah,
Because
just-
the valve is not aligned here.
Yeah, take your time. Eliminate the parallax. Adjust your LAO caudal.
So back to
Maybe we go through
the
LAO code then.
same LAO projection, LAO columns.
We have very good hemodynamics here after 130/6 of blood pressure.
And it's narrow complex, no ECG changes. One of the good things about 29 in such anatomy that you are away from the LVOT, as you are undersizing the valve for the LV, so you are not touching the AV
The
node.
conduction system.
20.
So,
Inject.
so Dr. Saeed,
So the gradient from central from the wire itself.
The problem
It's from the problem from the wire.
yeah.
Yeah, so we're probably going to do another injection once we get rid of the wire, but we want to
Yeah.
show you simultaneous pressure gradients.
I wouldn't actually. So I was going to ask you, this patient appears to be on, that he's intubated, right?
Yes.
Yes.
Okay, so in our center, we would have actually done with zero contrast in this patient because of stage 5 CKD. We depend a lot on 3D TEE in such high-risk patients. And I think, I mean, the number of injections that we have already done are too many. Just because it is a live case, we don't have to use that many injections. I would not actually do any more injections. If you want to look at PVL, take the pigtail, put the pigtail in the left ventricle, take the Lundaquist wire and drop in a TE probe, 2 minutes, you will assess everything and take it out.
Okay.
Yeah.
Actually, we'll try to show you transthoracic echo. Maybe we'll get a good
Yeah.
result with transthoracic. Good
So you have to take another view, dry cine in orthogonal, like in you go REO to make sure that there is no indentation, hidden in this view.
Yeah. So maybe we can go another REO crane.
Your cusp overlap view.
No, this is not.
Very good cusp overlap. Cusp overlap, REO code.
But you weren't happy about the parallax there.
Yeah, here. Take this.
Why is not clear for me?
No, there was too much parallax there.
Yeah,
But there is no constriction.
you can go more caudal, just make the 3 dot in the same
Yeah.
line.
Come more quiet. Come
Or
on.
are you?
Extreme code.
Keep going, keep going, keep going.
Keep going until they are
Yeah.
aligned.
Yeah, keep going. I think this is it.
So I think
Oh,
before
That is,
before removing the wire, we can take a simultaneous pressure just to see what.
We'll show you the pressure.
That's what we're planning to do.
Okay, let's do your holding.
Yeah. Okay, so I'm going to apply pressure here.
You will apply.
We need to put a sheath.
Okay, what's the sheet?
but do you see the indentation?
So I'm putting a pigtail, Khalid.
Yes, Dr. Mohammed, we're exchanging out to a sheath and then we'll put a pigtail in the LV and we'll get you some simultaneous pressure tracings.
Okay.
خذ أحمد. أحمد السعيد كوتا.
Somebody can do the echo meanwhile.
Yeah.
Okay.
Ready?
Problem?
Yeah, just advance the wire a bit. Okay. One second. Okay.
Go.
Okay.
One of the things you can put the big tail, it gives you less regurg if it's central. By the time you do the transthoracic echo.
We are getting actually. They are doing the echo. Do you want to show us the echo, guys, or?
Yeah, once we are ready, yeah.
Okay.
They're lighting up the machine. Okay. I got it. Thanks. Can we get a picture of catheter, please? Okay. Can you pass me a flush if you don't mind?
Hatim, just for the audience, what's your target ACT for procedure like this?
More than 300. Target ACT.
Oh, yeah.
No, it's above 300. Usually we're
Yeah,
above
right.
300.
I have it. Go on. Can we connect the pressure?
Okay, here's the picture passing of prosthesis. Okay. All right.
Present. And we'll give them central.
Yeah. We'll just re-zero the tracings for you. Yes, we will.
Push.
Meanwhile, we can get the echo, guys, till you get the hemodynamics correctly. Who's doing the echo? Hatim, who's doing the echo?
Dr. Ahmed was around.
The hemodynamics look very good.
They're just scrubbing it. They're here.
They're in the way. Dr. Ahmed Saeed is doing echo, he's in the way.
So this is all zero, right? Yes. All right, so we have a pictorial catheter in the proximal ascending aorta. This is the one above the prosthesis. And we have a pigtail across the prosthesis into the LV. And I hope you're seeing the simultaneous pressures. There is no systolic gradient, or hardly any. We'll get you mean gradients now.
Yeah,
Can you measure the mean gradient?
they look very good. We only have 3 minutes actually for the time, I guess.
Yeah.
If you don't.
Yeah.
Okay.
And I suppose judging by the diastolic blood pressure, I think we can, we'll get the echo images, but we can probably safely assume that we don't have significant leak around the prosthesis.
The slope of your LVEDP is slightly more acute than before, but I agree with you. I don't think it's going to be anything severe that you have
Can
to do
we
anything
get
about
the
it.
camera to the, can we get the camera to the,
Anybody using AR index now? Or it's a history now?
It is a historical index, and it's very useful, but it's not commonly used right now.
we need to get the
Well,
camera
do you use
here.
I think there is, Hatim, do you think there is enfolding in the cusp overlap view? There is a mild enfolding, I think, very clear. If you do dry cine, it will be more clear.
Okay, we'll do that. We'll just get the echo out of the way and then we'll get you your glycine.
Yeah.
Nothing serious, but
Yeah.
I think the other thing you notice here that even in the extra systolic beats, there's hardly any systolic gradient. So
You're right. So please, I mean, we are not very sure about the infold or not. You can check in different views and
we
confirm
will,
that.
as soon as the echo is done. Yeah.
Yes, yeah.
So we're scanning the patient in the apical 5-chamber view. I don't see any regurg.
Can you put the camera on the echo? Yeah.
can we get the camera? We need this up. Put it up so that they can see it. From here, from here, from here.
I think there is enfolding.
Hatim, if there's a concern for unfolding, it usually presents as AI rather than a systolic gradient.
Yeah.
So, so you want to really look at that if there's concern.
Yeah. So we're just scanning him right now as we speak.
Yeah. I mean, I think in view of time, probably the diastolic pressure is 60. Whenever in self-expanding valves, if the diastolic pressure is 60, I'm done. I'm all walking out of the room. My fellows are closing up. And so I don't think that there is any significant PVL. Even if there is mild, it will expand more.
Give us
So
the
on the echocardiogram, I don't know if you can see the screen, but we've looked in two views, the orbital 5 and the parasternal long, and we don't see any leak around the prosthesis.
Okay, great.
Can you show us the short axis and the apical for
Short
chamber?
axis, please.
And apical for chamber.
Okay, short axis.
Okay.
Maybe we can get the picture out right now.
So you see the valve is a circle,
Sure.
not much of PBL.
We're concerned there might be infolding.
I think you did a great job, guys, and
Yeah.
excellent result.
Yeah, very good. So the valve is circle.
We'll share some Balsinis just to put that question of possible infolding to rest. We'll send them to Dr. Muhammad, our anchor person, to share with the rest of the panelists.
Okay.
So there is some mild leak. We can
But
see
this is going to close in the next maybe 24 hours because it's
Yeah,
retinol
those
and it's going to
yeah.
expand. So very good job, guys. Thank you very much. Great job.
Excellent.
Challenging case, yes, but you did it very well. Comments from the panelists, final comments from the panelists.
Really, it was a very educational case, and the results are really amazing, and the sizing of the valve was accurate in my point of view.
Okay. Dr. Tariq?
You can't argue with success. It was a challenging case with an excellent result.
Okay, very good. Dr.
Quite well.
Ramesh?
Very well done.
I like the harmony between the two operators. You did a great job, beside a great result. Thank you very much.
Okay. Okay. Thank you very much, Hatim, Khalid, the whole team. Do you hear us? Hello?
Yeah, we hear you. Yeah, we hear you. So maybe just final comment from Dr. Hatim.
So we appreciate the opportunity to share this live case with the esteemed panelists. And I think there are quite a few interesting learning points raised here on what to think about the next time we're planning a TAVR in a bicuspid valve. I'm really grateful to the input from all the panelists and the audience. And thank you so much from us, myself and Dr. Khalid, and the entire team, technologists, anesthesiologists, and the nursing staff. Thank you so much.
Okay, very good.